Neurology, pathology, seizures. All right, so first off, let's define what a seizure is. A seizure is just multiple neurons firing in a synchronized pattern at the same time. Because usually what our neurons are doing, they're firing at different times, right? And that's just how they're communicating with one another. You obviously aren't going to have all the neurons in your brain communicating at the same time to do some different type of action, okay? But when that does occur, that leads to a seizure, okay? When you have synchronized firing simultaneously at the same time, right, of the neurons, you're going to have a seizure, right? So that's why when you look at a person that's having a seizure, they have like these rhythmic movements that occur throughout the body, okay? So that's just what a seizure is overall. Now there's two types. You have focal seizures and you have generalized seizures. Focal seizures are just located in one area of the brain, okay? They're focal, right? They're localized. It affects only a single area, okay? And it most commonly originates from the medial temporal lobe, okay? The medial temporal lobe is where it usually originates, okay? Now, it's going to present in two separate ways. It could be either focal aware or focal impaired. Now, focal aware just means that the patient is having a seizure, a rhythmic, jerky movement of one extremity, right? Because it's going to be a focal seizure that will only affect one area of the brain. So that means it will only affect one area of the body. So you're usually going to see like a rhythmic, jerky movement of one extremity. But focal aware is that they maintain consciousness while having that weird movement of the one extremity or one area of the body. Focal impaired means that they're going to have loss of consciousness during that time, during that episode of movement of the body or movement of one area of the body, specifically the extremity, okay? Then you have epilepsy, okay? Epilepsy is going to be essentially recurrent, okay, unprovoked seizures. So constant random episodes of unprovoked seizures that have just been recurring throughout the patient's life, okay? Now, recurrent focal impaired awareness seizures, okay, is usually going to be preceded by a distinct aura, okay? So someone might have an olfactory hallucination, like they smell burning, okay? And then they go into a focal impaired seizure where they're moving their hand and they lose their consciousness, okay? That is a classical sign of temporal lobe epilepsy, okay? So whenever you have like recurrent focal impaired seizures that is preceded by some type of like aura, that means they're trying to tell you that it's going to be a temporal lobe epilepsy. Okay, so I hope you understand that fully now. So if a patient comes in and they have symptoms of focal impaired seizures that are recurrent, okay, and they say it usually is preceded by the smell of rubber or smell of something burning, or they have another type of hallucination or aura that occurs prior to it, then they're trying to hint you at it being a temporal lobe epilepsy. And the most common cause of temporal lobe epilepsies are going to be hippocampal sclerosis. Okay, so they're going to ask you that. They'll ask you, okay, they'll tell you the patient's presentation. He comes in, he's been having focal impaired seizures since he was a child, okay? And he tells you that they're usually preceded by the smell of burning wood, okay? And then they'll ask you, what's the most likely cause of this? Well, you already know that he has a temporal lobe epilepsy, but the answer is going to be it's caused by hippocampal sclerosis. And what causes hippocampal sclerosis? What causes any sclerosis in the body? Exactly, damage, okay? So that's like reactive gliosis, like astrocyte proliferation in response to any injury. So the astrocytes, so if you had like an injury previously, like for example, if this kid had multiple febrile seizures in the past, that led to like reactive gliosis, injury in the brain, which led to astrocyte proliferation in the area, which essentially led to the final result of hippocampal sclerosis, which gave him an increased risk of having temporal lobe epilepsy. All right? Does that make sense? And then overall, the temporal lobe epilepsy will present as recurrent focal impaired seizures preceded by auras, okay? I hope that's clear as day, okay? Because that's a question that they love to ask about. They love focal seizures. That's one of their favorite things. And focal seizures are going to be that rhythmic, jerky movement of one extremity because it's focal. It affects only a single area. Okay. Next is going to be status epilepticus. Status epilepticus is just continued seizures, okay? Greater than 5 minutes, or they don't even have return to baseline, okay? So they might stop seizing, but they don't return to baseline. That still is considered status epilepticus. Okay, so greater than 5 minutes, or they seize, they don't return to baseline, and then they have like another seizure. That's still status epilepticus, lasts longer than 5 minutes. This is scary. We don't want the body to continuously be in a seizure episode because seizures are very, very scary, right? So the way that they treat it, and they want you to know how to treat status epilepticus, that's the most important thing for step one, is you have to give the patient two things, lorazepam and phenytoin, okay? You have to give lorazepam first because lorazepam is going to initially stop the seizure. Phenytoin acts a little bit later, so you kind of have to give them both, but lorazepam first because it's quicker acting, okay? Very important to know that, but lorazepam and phenytoin, all right? Next is generalized seizures, okay? Generalized seizures is just going to be a diffuse problem, all right? Instead of focal, it's going to be diffuse, okay? And the number one thing that they love to ask you about for generalized seizures is absence or absence seizures, okay? Absence seizures, the patient is absent, okay? So they're not moving their body like crazily that you see in the tonic-clonic type of seizures. They're not biting their lips. They're not having they're not peeing themselves. Like all that stuff is not there. The absence seizure or absence seizure is it's going to present in a child who isn't paying attention in class, and they're just dazing off in the middle of their class, okay? That's something that they love to test on, okay? And they'll say the teacher is angry at him because he's not paying attention, he's inattentive in class, and he's not paying attention to his mother, and he's just sitting down and just staring off into space. That's absence seizure. They're going to try to get you to pick a psych type of pathology. Don't get rattled, okay? Now, what they like you to know about absence seizures is that on EEG, okay, you're going to see a 3 hertz spike and wave type of pattern. So a 3 hertz spike and wave type of pattern is indicative, pathognomonic for absence seizures, okay? They really, really want you to know that, okay? Now, one of the main things that they also love to test on for absence seizures is going to be the treatment, and that's ethosuximide, okay? Ethosuximide is your treatment for absence seizures. I mean, you can give them other things, but that's going to be one of the key things, okay? Now, the last thing I'm going to be talking about is our juvenile myoclonic epilepsy. Juvenile myoclonic epilepsy, okay, it's a different form of epilepsy. It's going to present in a patient that wakes up with myoclonic jerks, okay, from sleep. So right when they awake from sleep, it's morning time, they wake up, they start to have this electrical shock-like pattern or movement in both of their arms, okay? If you ever see that, start thinking, whoa, this might be juvenile myoclonic epilepsy. It's so weird. The patient wakes up from sleep, and then they have these random rhythmic movements in their arms, electrical shock-like pattern. It's myoclonic type pattern, okay? That is juvenile myoclonic epilepsy, okay? The patient's otherwise healthy, and you treat them with valproic acid, okay? You treat the patient with this juvenile issue with valproic acid, all right? That should be pretty much all for seizures. I know it can be confusing, but I hope that this is just kind of helpful.